Assalamu alaikum.
Walaikum assalam.
I hope everyone is well. Apologies for a few minutes delay. I was trying to, a bit struggling with my connectivity. We will not wait, and I welcome our respected faculty, Dr. Abu Bakr Bhatti, who's a consultant surgeon at Shifa International Hospital. And Dr. Faria Sheikh has kindly joined us. She's a medical oncologist at Jinnah Hospital, Lahore. I also welcome Professor Khalid Rani, who has graced this meeting, and Professor Arvind Chaudhary, the president of SOS-PK. I will request Dr. Muniza Rasan to kindly start her presentation. Thank you very much.
अस्सलाम रज़ा भाई, this is Harun Javed. क्या हाल है आपका? ठीक है?
अच्छा, वो
I don't see Muzna still online. I think she will take 2 minutes to connect.
Sir, she is online. Gigi, she is online. I think she's logged in with a different account.
Right. Great. That's great. Thank you. Hope all is well.
Yes, sir. Sir, I'm sorry I can't share the screen. Says host has disabled participant screen share. Okay, now. Assalamu alaikum. My name is Dr. Muznali Khan. I'm a general surgery resident at Sheikh Zayed Hospital, Lahore. Today, my topic of discussion is the PREOPANC trial. I hope everyone can hear me. PREOPANC trial is basically a preoperative chemoradiotherapy versus upfront surgery trial. The background is that usually the standard treatment for pancreatic ductal adenocarcinoma is resection followed by chemotherapy. But the Dutch Pancreatic Cancer Group decided to assess the overall survival of a neoadjuvant chemoradiotherapy versus the standard treatment, which is the upfront surgery. The importance of this trial is that is the first published multicentric randomized trial in the neoadjuvant respect. The adjuvant trials, multiple of them have been published before. The study design is basically, it's a phase 3 randomized controlled trial, which was conducted in 16 high-volume pancreatic surgery centers in Netherlands between 2013 April and July 2017. 248 patients were selected, which were randomly assigned into 2 groups. One of them was given preoperative chemoradiotherapy, and the other one received upfront surgery. The inclusion criteria was patients without any distal metastasis, a tumor which is either resectable or borderline resectable. The definition of resectable is a tumor without arterial involvement and with venous involvement with lesser than 90 degrees of venous involvement on a contrasted CT scan. And a borderline resectable tumor is one with lesser than 90 degrees of arterial involvement and or venous involvement between 90 degrees and 270 degrees, but without any inclusion. Also, WHO performance status of lesser than or equal to 1 was included, 0 being a patient who is active and 1 being a patient who can do light work. The adequate hematological, renal, and hepatic function was also required. The exclusion criteria was a T1 tumor without any vascular involvement, a history of previous malignancy within 5 years, and any previous chemoradiotherapy that precluded the treatment. Here you can see a table. in which it's clearly shown that these are two groups. Preoperative CRT group had 119 patients and immediate surgery group had 127 patients. The patients were fairly similar. There were 46% of females in the preoperative CRT group versus 42% in immediate surgery group. The pancreatic head tumors were 82% in the CRT group and 92% in the immediate surgery group. Resectable pancreatic cancer was 55% in the preoperative CRT group and 53% in the immediate surgery group. Again, same percentage with the borderline resectable pancreatic cancer, 45 and 47, quite comparable. So for the neoadjuvant CRT group, 119 patients were randomly chosen, and each of them had to go through a staging laparoscopy to rule out occult metastasis. And then biliary drainage. Dr. Shiraz. Okay. Okay. So 119 patients were randomly chosen to the neoadjuvant CRT group, and all of them had to go through a staging laparoscopy to rule out the occult metastasis. And then patients who had deranged bilirubin, they had to go through biliary drainage, so that before the chemotherapy was started, their bilirubin level was less than 1.5 times normal. So within 4 weeks of randomization, CRT, pre-op CRT had to 3 courses of gemcitabine, 1,000 milligram per meter square was given. First dose at day 1 and 8 of 3 weeks. Second dose was combined with the radiotherapy, 15 fractions of 2.4 days in 3 weeks through pancreatic tumor and also the suspicious lymph nodes. And along with that, on the first, 8th, and 15th day of 4 weeks, gemcitabine was also given. The third course was at day 1 and 8 of 3 weeks. You can see this picture, which you can see day 0, week 0 is the time when patients were randomized. And then this arm 2 is basically pre-op CRT group, and arm 1 is the upfront surgery group. In the pre-op CRT group, everyone had to go through laparoscopy and then 3 cycles of courses of gemcitabine, and the second one given along the radiotherapy. And then later on, staging CT scan was done, and within 14 weeks and 18 weeks, exploratory laparotomy was done, and then 4 courses of adjuvant gemcitabine were also given. For upfront surgery group, 127 patients were randomly chosen, and it was upon the surgeon to perform laparoscopy, staging laparoscopy or not. If the bilirubin was more than 250 millimoles per liter, then biliary drainage was performed. Surgery was done within 4 weeks after random assignment, and then 6 courses of adjuvant gemcitabine at 1,000 milligram per meter square on day 1, 8, and 15 of 4 weeks after resection and confirmation of pancreatic ductal adenocarcinoma were done. Here again, you can see arm 1. At 4 weeks, surgery was performed, and then later on, 6 cycles of gemcitabine were given. And at the end, in both of the groups, evaluation was done with CT scan and CA19 9 levels. The type of surgery, according to International Study Group on Pancreatic Surgery, for pancreatic head tumors, the classic or pylorus preserving pancreaticoduodenectomy with local regional lymph node dissection was performed. And for body and tail tumors, a body and tail resection with splenectomy was done. Follow-up was CT scan with CA19 9 levels at 6, 12, and 18, 6, 12, 18, and 24 months after random assignment to groups. This is just a presentation showing that a total of 248 patients were chosen, randomly divided into 120 pre-op CRT and 128 immediate surgery, out of which, out of both the groups, one patient did not consent. So we were left with 119 and 127 patients. Then patients with upfront surgery who had to go through upfront surgery. Some of them died, some of them had disease, 4 of them had disease progression before surgery. So out of 127, 121 patients actually received surgery. And out of 121, only 91 underwent resection due to various reasons: locally advanced disease, metastatic disease, and both together. And then post-op chemotherapy was done in only 65 of those, so follow-up was 4. In patients with pre-op CRT, out of 119 of them, 114 received laparoscopy due to various reasons, and then only 91 out of 114 actually started pre-op CRT, and out of those patients, 82 of them received surgery due to death, disease progression, and out of 82 of them, only 72 underwent resection due to locally advanced disease and metastatic disease. So the primary endpoint for this research is overall survival with intention to treat, and the secondary endpoints being the disease-free survival, local regional failure-free survival, distant metastasis-free survival, and margin negative resection rate. So the results, if you look at this table, the significant ones are highlighted. So the overall mean survival for the pre-op CRT group is 16 months and immediate surgery group is 14.3. And the results are not significant. However, the secondary endpoints had better results. For example, disease-free survival in median disease-free survival is 8.1 months in the pre-op CRT group and 7.7 in the immediate surgery group. The confidence interval is 0.55 to 0.96. And for local regional failure-free interval, also there is a significant result. And out of all of them, most significant is the R0 resection rate. In 71% of patients who receive preoperative or neoadjuvant chemoradiotherapy, R0 resection rate was achieved. And out of 127 immediate surgery patients, 40%, only 40% had R0 resection rate. Also, pathological lymph nodes in pre-op CRT group were 33% versus 78% in the immediate surgery group, which was also very significant. Now we're going to look at the survival curves. Again, the overall survival was not significant here, as they're quite similar results, the blue being preoperative chemoradiotherapy and the red being immediate surgery. However, the disease-free survival, you can see a difference, and the major difference you can see in local regional failure-free interval, in which preoperative CRT was superior. Now further dividing the groups into resectable pancreatic cancer and borderline resectable pancreatic cancer group, you can see that in this resectable pancreatic cancer group, none of the primary or secondary endpoints were significant. However, if you look at the borderline resectable pancreatic cancer group, even the overall survival is significant. In pre-op CRT group, 17.6 months survival is seen, and in immediate surgery group, 13.2 months survival is seen. So this is significant with a p-value of 0.029. And again, same goes with disease-free survival and local regional failure-free survival. And again, R0 resection rate better with borderline resectable pancreatic cancer. So this initially study did not show any significance. However, a recent follow-up PREOPANC study was published in January 2022 that showed that on follow-up of those patients after 5 years, median follow-up 59 months, overall long-term survival had improved for patients with resectable and borderline both resectable patients who received neoadjuvant and adjuvant gemcitabine, and it was an improvement by 14%. The 5-year overall survival was 20.5% now. Now you can compare, this is the new 5-year overall survival curve, and you can see there's a major splitting difference. As initially we finished here, and now it is significant. P-value is 0.025. And the blue one being upfront surgery and red one being neoadjuvant CRT. So obviously patients are surviving here. And if you look at the other table, the red and orange ones are neoadjuvant CRT ones, and the blue and green ones are the pre-op surgery ones. And you can see that in both resectable and borderline resectable groups, there is a benefit of neoadjuvant chemoradiotherapy. So these are a few recent trials, as well as some ongoing trials. As I told you earlier on, that adjuvant chemotherapy was published before as well. For example, the SPAC4 trial showed that adjuvant capecitabine oral along with gemcitabine was far superior to gemcitabine alone in monotherapy. The overall survival was 28 months. And the FOLFIRINOX, which is modified fluorouracil, leucovorin, irinotecan, and oxaliplatin, this combination is better as compared to gemcitabine monotherapy as adjuvant chemotherapy, and the median overall survival is more comparatively better, even to the SPAC4 trial is 54.4 months. And now an ongoing PREOPANC 2 trial, results are expected in 2022. This trial is again on neoadjuvant therapy. It is comparing the gemcitabine-based neoadjuvant therapy to the total neoadjuvant FOLFIRINOX. And there is a NORPACT 1 trial, which is ongoing. It compares the neoadjuvant 5-fluorouracil, oxaliplatin, and irinotecan followed by surgery to again upfront surgery. And then this PANASH 1 trial, which is the neoadjuvant FOLFIRINOX-based chemotherapy in only resectable pancreatic adenocarcinoma group. It's also multi-centric randomized phase 2 trial, but it only focuses on the resectable pancreatic adenocarcinoma. So the discussion initially, as we saw, that the results failed to demonstrate any statistical significance of overall survival. However, with long-term analysis, we can see that the overall survival was improved. And secondary endpoints, even with the initial study, showed better results. And in a predefined subgroup analysis, where we saw that overall survival with pre-op CRT for borderline resectable made difference, but with resectable group, it was there was no difference. So, and This study was also beneficial because it spared us from like some futile surgical interventions, because a lot of patients were excluded who had advanced disease. And at the end, it is very difficult to compare these adjuvant trials that I discussed earlier on with the new adjuvant ones, because in adjuvant trials, you already select patients who have recovered from surgery and or better, as compared to in this new adjuvant group, where patients are receiving therapy for the first time. Now, critical appraisal. Is the study question relevant? Yes, it is very relevant. This is a very crucial study. It tells us about the future of neoadjuvant chemoradiotherapy. It obviously adds, it's a hallmark study. It adds neoadjuvant chemotherapy importance to, and it obviously does test the stated hypothesis. It lacks the time.
Unfortunately, I think we have lost Dr. Muzna. We will wait for her to join back. In the meantime, if maybe we can start the discussion with our faculty, Professor Khalid Rani, Dr. Abu Bakr Hafiz, Professor Harun Javed. Do you think the results of this trial can be generalized to our patient population?
Thank you, Raza. I think it was a good idea, discussing this particular point, because I'm one of the old school who's really, really interested and tempted in, upfront resections wherever possible. So I think, although it's not immediately applicable, a lot of my other colleagues, from who were trained in the previous century will be like me. So I think if such studies can help to generate certain studies in our own region, then we can maybe use our own data to see how this thing works in our own population. So staging laparoscopies and preoperative clinical staging has now become the rule. But as you know, that a lot of cancer surgery in our part of the world is going on in the district hospitals. So for those people, especially, I think because we invited the district surgeons to join also, but I think they're having their own laparoscopic, a cancer surgery workshop today. And the General Secretary of SOS-PK is representing over there, and they're performing some live operations. So that's one reason for a thinner audience today. But however, and I'd like to welcome Dr. Abu Bakr Hafiz Bhatti, because I don't think we've ever met, but I keep following him on Twitter. And Abu Bakr, if you're there listening, you're brilliant. Some of your operations that I've seen are really, really good. Well done to yourself. So I'll pass over to our panelists for their comments, and if Professor Khalid Rani wants to say something.
Yes. Hello, can you hear me?
Yes, sir.
Hello. Yes. First of all, I think we need to congratulate Dr. Saiba for presenting the results of PREOPANC trial. This trial, if you look at it, it is one of the first phase 3 trial on the neoadjuvant chemoradiotherapy. So that's why this is the importance of this trial. As far as the endpoints are concerned, the primary endpoint was a median disease-free survival. So the initial results, which were published about 2 years ago, showed not much difference between the median overall survival between the two groups. That is the trial group with neoadjuvant chemoradiotherapy and the upfront surgery followed by chemotherapy. Whereas the long-term follow-up has shown that at 59 months, the median overall survival by intention to treat analysis was 15.7 months in the neoadjuvant group versus 14.3 months in the adjuvant group. Again, the difference is not much, but still there is some improvement in the group of the patients who received neoadjuvant chemoradiotherapy. If you look at the survival data, 3-year survival in the neoadjuvant group was 27% as compared to 20% in the adjuvant arm. So there is a difference of about 7% survival advantage. Whereas as far as the 5 years survival is concerned, the difference is much more. It's about 14%. The 5-year survival in the neoadjuvant group was 20.5% compared to the upfront surgery group where it was 6.5%. But if you look at these results compared to the data from other specialized centers in Europe as well as North America, you would see that these 5-year survival data is somewhat to the lower side. And we already know that SPEC, which is a pancreatic cancer study group in Europe, they have produced 5-year survival of about 34 to 35%. And the lady has already mentioned that the PRODIGE trial, which is actually a French-Canadian trial with the use of FOLFIRINOX, they have produced a 5-year survival of close to 50%. So if you compare the results of PREOPANC trial with the other trials, it certainly is inferior to the results achieved either in the SPEC trials, which are the European trial, and also in the French-Canadian trial. Now, another positive point of this PREOPANC trial is that the secondary endpoints were definitely superior, which means that R0 resection rates were much higher in the neoadjuvant group compared to the adjuvant group. Similarly, the number of negative nodes were also much less in the neoadjuvant group. And also the presence of perineural invasion or perivascular invasion, this was also much less in those patients who received neoadjuvant chemoradiotherapy. So this signifies that the pathological response is definitely there if these patients are given neoadjuvant chemoradiotherapy. Now the pitfalls of the study, which I have noticed, is that there was relatively a lower resectability rate in the neoadjuvant group, which was about 61%, whereas the resectability rate in the upfront surgery group was 72%. The authors have an explanation for that, but I'm just telling the main features of the trial. The serious adverse events were 52% in the neoadjuvant group versus 41% in the adjuvant group. So it means that the neoadjuvant treatment is also associated with somewhat higher adverse events. The other point to note is, as I've already said, although the survival outcomes were slightly better in the neoadjuvant group, but if you compare it with other trials, like I've already said, the SPEC trials are the PRODIGE 24, which is the French-Canadian trial, they are much inferior. For example, in the PREOPANC trial, the median survival maximum was 16.4 or 16.55 months, vis-a-vis 35 months in the SPEC4 trial, which is the European trial, and 54 months in the PRODIGE 24 trial. So, but we have to keep in mind that these trials, the SPEC trial is about the adjuvant chemotherapy, which involves not just gemcitabine plus, it is gemcitabine plus capecitabine. Whereas the PRODIGE 24 trial, the French trial, includes the FOLFIRINOX, which is, I think, 4 drugs combination. So FOLFIRINOX certainly is a far more toxic combination compared to gemcitabine or gemcitabine plus capecitabine. So these things we have to keep in mind. The other point to note is that the survival advantage was more pronounced in the borderline resectable group of patients than in the resectable group of patients. And finally, of course, I am not sure whether the addition of radiotherapy to neoadjuvant chemotherapy has certainly produced better survival. So we still have to see in future whether it is chemotherapy which has improved, which has caused better survival outcome, or it is a combination of chemotherapy plus radiotherapy which has produced these results. Now, if you look at you will note that the same group, the Dutch pancreatic cancer study group, has started a new trial, which is PREOPANC 2, in which they will try this FOLFIRINOX in the neoadjuvant setting, and they will compare it with the gemcitabine and chemoradiotherapy in the neoadjuvant setting. And we still have to see the results of these trials. So I think, to cut it short, I am not yet convinced whether neoadjuvant chemoradiotherapy is the treatment of choice in resectable cancer, whereas in borderline resectable cancers, certainly one should try a preoperative neoadjuvant chemoradiotherapy and then reevaluate the patient for the purpose of resection. Thank you, Dr. Raza. Over to you. Dr. Raza?
Have any comments?
Yes.
Yes, Dr. Raza, can I just chip in with a few of my comments?
Yes, please, Dr.
Okay, so first of all, thank you very much, Dr. Raza, Dr. Majid, and the Society of Surgical Oncology for having me here today. It was a great presentation, very well presented, the PREOPANC trial. And I kind of agree with most of the comments that are made by Dr. Majid and Dr. Durrani. Just a few observations, or I would say where I would probably disagree a bit. So this trial at 5, I think probably this is the only trial which is actually completed 5 years after surgery. So the results of this trial are very important. So the actual 5-year survival has been reported in this trial in patients who had neoadjuvant treatment and stuff. So, and it is very clear that although when the interim analysis was done, there was not much difference, but now at 5 years, you start to see that the survival curves are actually kind of going away from each other. The problem with this trial is that the chemotherapy that has been used, gemcitabine, it's kind of outdated now. And I think that is the real problem with this trial, that, you know, when you talk about the applicability of this trial in terms of whether we can practice this in our clinical practice or not, then I think gemcitabine is probably not going to be there. So that's probably the real issue with this trial. In terms of comparisons with the other trials of adjuvant treatment, like Dr. Durrani Saab very clearly mentioned about the PRODIGE trial, where the median survival of more than 50 months was achieved. So we have to be very wary of the fact that, you know, these trials, for example, in the PRODIGE trial, they randomized patients after surgery when they had recovered from surgery, they had no complications, they had no metastatic disease, they were good ECOG, and then they were randomized to receive chemotherapy. So this was a very select group of patients, and that's why their survival was so good. While on the other hand, when you look at these trials of neoadjuvant treatment, these are basically intention to treat trials. So basically you start to calculate survival from the time these patients are randomized, and you include survival of patients who do not even undergo surgery. So I think it would probably be a little unfair to compare those trials with these trials. But if you talk about my personal view, I would agree with Durrani Saab that, borderline tumors, definitely they should go for neoadjuvant treatment. I don't think there is any question about that. But resectable tumors, I think we still have to be selective. Probably in the next 1 or 2 years, we're going to have more evidence about that. But in resectable tumors, if there is high CA19-9, probably more than 500, if there are clearly positive lymph nodes on preoperative imaging or maybe US-guided biopsy, I would probably go for neoadjuvant treatment. Otherwise, I would still go for upfront resection in these patients. So these are some of my thoughts.
Thank you very much. An important question, and I will pose this to Dr. Fariha. There is always a concern giving neoadjuvant therapy that the patient may progress and become unresectable, once the treatment finishes. What are your views on that?
First of all, I would like to say that the presenter has made an excellent presentation, and previous 2 colleagues have elaborated the trial in so much detail that I have no words to explain anything. Regarding your question, basically this trial is about neoadjuvant therapy. May it be a combination therapy of chemo plus radio or chemotherapy alone. You can extrapolate the results in that way as well. Basically, the neoadjuvant therapy filters those patients who are the patients who have an aggressive disease. They will likely progress shortly after undergoing this extensive surgery. So in my opinion, the patients who progress or who did not underwent surgery were the patients who obviously had to progress shortly after surgery. So this is a blessing in disguise that they were prevented from undergoing that extensive surgery, and they progressed and they straight away went for the palliative therapy or second line therapy.
Thank you very much.
And one more thing I would like to highlight and agree with that comment, that this trial only compared gemcitabine, and now we have more chemotherapy combinations and they have shown far more better results. So when this trial was recruiting patients, at that time gemcitabine was standard of care, but now we have different standard of cares with multi-agent chemotherapies, 2-agent chemotherapies. So we'll likely have better results when the newer trials which are recruiting now or are will have a long-term survival analysis of shortly. They will give us more better results.
Okay, thank you very much. One simple question to all faculty members: is it always important to establish the diagnosis? As we have seen, they had gone to quite elaborate length in establishing a preoperative diagnosis. Would you, what is your practice? Do you always have a preoperative EUS-guided ultrasound biopsy to establish diagnosis of pancreatic cancer? Does it make a difference if this is not pancreatic, if this is ampullary or cholangiocarcinoma?
Well, if you look at the data, it shows that endoscopic biopsies may be carried out, but the confirmation of cancer is not there in 100% of the cases. Maximum it is something like 60 to 70% of the cases you will get the diagnosis of cancer. In the rest of the cases, the pathological report may be inconclusive. Now, this is again an argument against neoadjuvant treatment, that if you don't have a clear-cut diagnosis, you are subjecting a patient to the toxicity of chemotherapy, or for that matter, chemoradiotherapy. So this is the definitive diagnosis is made only when the surgery is performed and you have the specimen in front of you, in which you can analyze the specimen, you make a proper diagnosis, and you can also find out the genetic nomenclature or the genetic sequencing of that particular tumor as well, so that in later stage, when these patients will recur, certainly most of these pancreatic cancer patients will either recur locally or distantly. When the recurrence occurs, then you may have to resort to immunotherapy. And in that situation, the actual biopsy specimen plays an important role. Thank you.
I would like to make a comment that prior to proceeding for any sort of neoadjuvant therapy, we need to have a tissue diagnosis, because with what we are dealing, we need to know whether because many a times we on biopsy specimen, we don't get pancreatic tumor, we get lymphomas, we get neuroendocrine tumors. So the treatment algorithm is totally different. So whenever we are proceeding for a neoadjuvant therapy, may it be chemotherapy or radiotherapy, we need to have a tissue diagnosis, even if the patient is resectable disease, is having a resectable disease, a borderline resectable disease, or even that is an unresectable metastatic disease. We need to have a tissue diagnosis before proceeding for any sort of therapy.
Can I comment on that, sir?
Yes, sir, please.
Just a short comment. Professor Khalid Durrani, yourself, and Abu Bakr. In real time, real life, and in our own setting, I found that now we are in recent times making efforts in all patients to try and get an EUS guided biopsy. But this is something which is very, very operator dependent, and the false negative rate is very, very high. So I think although this is standard procedure now, but it will take some time to evolve with better training and better experience also. A lot of things are concerned over here. So that's just a comment. But yeah, I think that in the cases that we are doing at Sir Zayed Hospital, we would have a definitive preoperative diagnosis in only 20 to 30%, somewhere between 20 to 30%. That would include US guided biopsies and very rarely ERCP brushings from that area, or direct biopsies, endoscopic biopsies taken from. I mean, we find those the most reliable if they can visualize something directly and on a lateral viewing scope or an ERCP and take a biopsy directly. That has the maximum yield. Otherwise, ultrasound or EOS guided needle biopsy, very, very high false negative rate. And we are, Dr. Faria is right. We have found even, tuberculosis and, reports of a villous adenoma in the distal CBD causing deep obstructive jaundice.
Thank you, sir. I can see that we have now been joined by another of our faculty members, Dr. Irfan Kabir, who's a consultant surgeon at Shaukat Khanum Memorial Hospital. Welcome, sir. Dr. Muzna has very nicely presented the findings of the study as well as the protocol, and we were discussing some of the findings. And we were entertaining this question if it is always necessary to obtain a preoperative diagnosis of pancreatic cancer in the form of EUS guided biopsy or any other means. What are your thoughts and what are your practices in obtaining preoperative diagnosis for pancreatic cancer?
So first of all, thank you very much, Dr. Raza, for the invitation, and I'll apologize to everybody for joining in a bit late for various personal reasons. I think that's a very interesting question that you have put forward. I'll give my few thoughts. Number one, I think all the updated guidelines so far, whether it's NCCN, whether it's the NICE guidelines, whether it's the ESMO guidelines, all of them, if you read the details, are against doing US for staging, are against getting a biopsy if it's upfront resectable disease. Coming to the paper itself, because for this kind of approach, you need to have a preoperative diagnosis. So you'll have to do a biopsy. One of the important things in all this PREOPANC is that it is not applicable to all types of pancreatic tumors. If you read the exclusion-inclusion criteria, tumors less than 2 centimeters, either T1 tumors, were never included into this study. And that's the group of patients who you're going to get the most benefit from. The other group which wasn't included in the study was the periampullary tumors. I don't know what the experience is outside of Shaukat Khanam, but however, in our cohort over the last 3 years that I'm seeing, almost 80% of our patient cohort is periampullary. We hardly see pure pancreatic cancers in our cohort. And there are multifactorial reasons for that. Most of them present at a stage where there's not much you can do about them in terms of staging and so forth. So the ones that are usually resectable are periampullary. Coming to your question, I think my personal thoughts are, if there's a double duct sign, if it is clearly resectable disease, if it is definitely less than 2 centimeters, then I don't think there's any need for EUS or biopsy for that matter, and upfront resection should be offered. Now, whether the current practice reflects that, unfortunately it doesn't, and there's, I think, a lot of cultural reasons for that, and endemic practices in the society which we haven't been able to change, either in organizations as well, but that does need work. But my personal thoughts are clearly resectable disease, less than 2 centimeters, favorable position of the tumor. I think that's the most important thing. And any of these trials that we've seen, whether it's PREOPANC, whether it's the other European trials, the Japanese trials, you will see that nobody talks about the position of the tumor, the location of the tumor, whether it's in the head, whether it's in the Uncinate process. And I think that makes all the difference between your resection rates, the resection clearance rates. So my thoughts are periampullary tumors less than 2 centimeters, clearly resectable. I don't think you need EUS, or you don't need biopsy either, and you should go up for surgery.
Thank you very much. Thank you for pointing out the specifics in the inclusion and exclusion criteria. And we can see it's not just the T1 tumors being excluded. It's the included tumors were tumors that had something to do with the venous involvement, in the sense either they were resectable but had less than 90 degrees of venous involvement, or borderline resectable based upon venous or arterial involvement in that sense. In patients who have a mass in the endopancreas which has close contact with the SMV or portal vein, even if it is less than 90 degrees of the circumference, would or should we consider neoadjuvant therapy open to all faculty members?
If everybody's okay, I'll take that on, and then we can hear other faculty members. I think what we should offer, what we shouldn't offer, depends on what the local expertise are, what the organizational expertise are, and what are the skill sets available. And I think this applies across the world. Even in the European centers, we will see some centers which are very aggressive, and they will take on tumors with abutment involvement of the vein, and they'll go up for upfront resections, even if it's just abutting the tumors. But those units are very comfortable doing venous resections. Whether the outcomes of those resections match those that go the neoadjuvant approach, I still think there's a lot of debate on that. I don't think we have an answer for that yet. Even though some of the studies might tell us that neoadjuvant approach is better, I think we don't have an answer yet for these kind of tumors. So I think in Pakistan, we have to take into account the financial constraints of patients. We have to take into account the limitations in the skill sets available. We should be guided by that. So if we have a unit which is transplant based, they are very comfortable doing venous resections, they get patients who may have upfront resection, then I think those units will prefer to do venous resections as an upfront. Those units where the surgeons may be a bit reluctant to take these kind of patients on, you may find that those are the units which may be going down the chemoradiation routes. which one is right, which one is wrong, I don't think I have an answer for that. And I think we still need more evidence to see which one is the right approach.
Speaking of transplant, I would direct the same question to Dr. Abu Bakr Respectable, so who works in a very busy transplant unit. Sir, what is your practice for patients who have venous involvement but are not classified as borderline resectable?
Yes, so Dr. Azad, the thing is, again, as I think Dr. Irfan Kabir has also pointed out, that we also have a similar experience that we hardly get any pancreatic cancer patients. I mean, majority of our patients are ampullary or distal cholangios, So, but when talking strictly about pancreatic cancer, because out of these four etiologies, I think pancreatic cancer is the worst. And so basically, it has been shown that even for tumors that are up to 2 centimeters size, 80% of patients have micrometastatic disease, even when the tumor is at like 2 centimeters in size. So pancreatic cancer is a systemic disease to begin with, so no matter what sort of surgical resection you are going to do, whether you take out the vein or not, you would have micrometastases. And that is the whole rationale of neoadjuvant treatment. So coming back to your question, I mean, somebody who has any venous contact, although we used to, like probably 3-4 years ago, we used to just go for upfront resection, and if the venous resection was required, we would do that. But now I don't do that. I would send these patients for neoadjuvant treatment. Also, those patients, as I just told you, that even if there is no venous involvement, but the CA19-9 after biliary decompression is, let's say, more than 500, 800, 1000, I would like to send them for chemotherapy and then assess the response, because, it is really embarrassing that sometimes we do these big resections and our patients come back to us in 3 months with diffuse peritoneal metastases. And it's really very difficult to explain to them what has gone wrong. So for me, I would go for neoadjuvant treatment.
Sir, Professor Harun, Professor Khalid, Dr. Fariha, any comments from your side?
Yes, I think Dr. Bhatti has raised a very important point of the biology of the tumor. So like everywhere else, we have to look at the ABC of the cancer. And pancreatic cancer, when you say it is resectable, generally it is meant that it is anatomically resectable, but we must also consider the biological aspect of this tumor, which is, for the time being, all we have is CA19-9. So I certainly agree that a patient with a very high CA19-9 over 500, and especially 1 over 1000, may be offered neoadjuvant chemotherapy. And the third aspect of this ABC is the physiology of the patient, that we also have to look into, because we all know that, especially in our setup, patients with pancreatic cancers, they suffer from generalized weakness, anemia, and they have advanced jaundice and impaired liver function. And along with liver function, their renal function may be impaired, and they have sarcopenia. So if a patient has got a reversible morbidity, then these patients should not be taken to upfront surgery, and maybe a neoadjuvant regimen be considered. Thank you.
Thank you, sir.
Definitely, because when the CA19-9 levels are high and there is high nodal burden, the size is more, then there are higher chances of micrometastasis. As I previously said, that this is the group of patients who will shortly recur after surgery. So these will be the patient who will achieve a maximum benefit from neoadjuvant chemotherapy, because they are resectable, but considering the risk of earlier metastasis, they will get the maximum benefit. So in this set of patients, they definitely need neoadjuvant chemotherapy or chemoradiotherapy.
Thank you.
I think, Dr. Raza, on that note, the Japanese recently kind of published a very nice paper on this whole debate. And this is an ongoing debate which has been going on for the last 15, 20 years across the world, whether you should go for the neoadjuvant, upfront surgery, adjuvant. We still don't have an answer. People add in radiation, they add in intraoperative radiation, then we go to systemic radiation, then we have going around in circle. People are now talking about HIPEC in pancreatic cancers and everything. So I think this debate is never going to end, because the questions which we ask are not the right questions, I think, personally. The Japanese have come across with this very nice paper where they're actually talking about the physiology, the biology, and the positioning of the tumors and the resectability and all that. And what they've come to the conclusion is you cannot take one size fits all approach in pancreatic cancer. Every case that comes through that door has to be assessed and acknowledged in its own merit, in its own assessments should be done. And then every case should be individualized. Some patients may benefit from surgery, some patients may benefit from upfront chemotherapy, FOLFIRINOX, or whatnot. We don't have an answer for that yet either, which chemotherapy regime is the right one. So I think, you know, it's individualized approach that has to be pushed in pancreatic cancer rather than one size fits all.
Thank you. That's, I think, a very important message, that there are many factors that should be considered in order to individualize the most appropriate management for each patient. Looking at the survival curves, which were the primary outcome for this study, as Dr. Muzna very elaborately mentioned, we did not see any significant difference in the beginning or the earlier part of the study that was published. But as the follow-up period increased, we see a separation of the curves. Is there any reason that could explain this difference that came on quite late? And obviously this is the reason, possibly one of the reasons why there was not such a significant difference in median survival, because this separation of the curve started after the overall survival had reached less than 50% of the events.
To me, it is still the early cure of that micrometastatic disease, because majority, the separation of the curve is after a certain time. Then it means that the metastatic potential of that tumor has been treated earlier, or it is dealt with earlier. That is why initially there was a good local control. That is why initially the curves remained the same, but they separated after a certain period of time. That was because the micrometastatic potential was treated at the right time for those patients. Secondly, one more thing, majority of the pancreatic cancer patients who present in our group of patients or Pakistan, they are weak, emaciated, because they don't have that good nutritional status. We are talking about the trials which are done in Dutch people or US population. They have very robust physical health and status. Our physical status can't match with those. Our patient population has different sort of health issues. So most of the patients which we deal with are emaciated, they are weak, they are not eating. So when we start with neoadjuvant chemotherapy, they have a time to build up their nutritional status. We cater with their nutrition and they improve a bit. And then when they undergo that extensive surgery, even if after the surgery they cannot complete their planned post-operative chemotherapy sessions, they have received enough chemotherapy before surgery. So that effect is taken over for a longer period of time, because in patients who undergo upfront PREOPANC, we see many patients who are not able to receive post-operative chemotherapy because of their frailty and co-mobs and weak nutritional status. They come late after the window of the chemotherapy. So with the neoadjuvant chemotherapy, they'll be able to receive some sort of chemotherapy or complete course or some courses of chemotherapy pre-operatively. So there will be better outcomes as compared to the patients who will not receive any chemotherapy after that extensive surgery.
So can I add a comment here? I think, Dr. if you don't mind, I think there is a slight danger which we might be pushing with this paper, and everybody may be thinking that let's just start neoadjuvant therapy in all our patients. So I think the first thing we need to keep okay, this paper probably is not applicable to our population at all. So let's not take out a message that every patient who comes in with pancreatic cancer in, say, Karachi or Peshawar or Islamabad should go down the neoadjuvant route. And I think that would be setting a very dangerous precedence. The reason I'm saying is, again, ours are mostly periampullary cancers. These are mostly pancreatic cancers. So again, this paper does not address what we face here. The second thing is, if our patients are emaciated and weak, you're not going to give them FOLFIRINOX, you're not going to give them gem-paclitaxel, and then the question arises, giving them being alone as a neoadjuvant therapy, which may be not helping at all, then the question is, are we doing these patients any benefit at all? Because if they're emaciated, they will not tolerate the FOLFIRINOX regime. You need young, fit patients to tolerate that regime. And an emaciated patient will not tolerate that. And any chance that he may have had is probably not going to be there at all. So I think, again, the take-home message from this session should be that we need to find a better way of managing our patients. We need to find local solutions to local pathology, and we may have to do some sort of collaboration or some assessments along the local lines to see if this works for us or not, rather than just deciding that we are going to go down the neoadjuvant route. I think I just wanted to come back, clarify this one point.
Can I take a short comment on that?
I would like to answer. Sorry, we don't use FOLFIRINOX in our population because our patients don't tolerate this triple agent chemotherapy. So we limit ourselves to double agent because we know that our patients will not tolerate, and they don't tolerate FOLFIRINOX, most of the patients. So we need to have our local data and our local set of guidelines to set an algorithm for our local population of patients.
Thank you, Dr. Faria. Dr. Harun, did you want to make a comment, sir?
Yeah, just a short comment in support of what Dr. Irfan was saying. Actually, if you, I mean, there's the whole of Pakistan, but if you look at just the Lahore region only, and if you look at the journey of the pancreatic or that region cancer patient as it is, anybody with the label of cancer first goes to Shaukat Khanum Hospital. So Shaukat Khanum generally has a choice, and they have an acceptance in the referral criteria, and the next stop in the journey is 3 hospitals, because the next specialist known center is PKLI now. But then there's Sheikh Zayed Hospital, which has a dedicated HPV and liver transplant unit, and 2 general surgery units, which are also doing pancreatic cancer surgery. And then there's Lahore General Hospital and Jinnah Hospital on the way. So the kind of patients that we get, and especially in Sheikh Zayed with an HPV unit there, first choice Shaukat Khanum has, second choice HPV unit has, and whatever is left behind is with the general surgery, doing surgical oncology now. So I strongly agree, and also suggest that we need to develop our own guidelines, as was done 2 years back by the huge efforts of the Society of Surgeons of Pakistan Lahore chapter, that local guidelines for breast and colorectal cancer were developed. So I think a think tank needs to be developed on a national level with all the pancreatic experts and the HPV surgeons, and then maybe some guidelines we can come up with, and also maybe there may be some ideas which may be generated for future trials within our own country. I know with all the local constraints regarding finances, poor patients, logistics, training of the surgeons and everything, and people's own experiences, prospective trials are extremely difficult to carry out in our own country. So I strongly suggest that there should be a pancreatic group, and maybe you guys can take the lead on that.
Yeah, Dr. Azza, I would just like to, this is very interesting. neoadjuvant versus adjuvant. So you see, even when you have to make some local guidelines, you need to have local data. That is very important. Otherwise, your guidelines are going to be based on international data. So it is probably better to then follow international guidelines, you know. But having said that, if we talk about local data, I mean, I can tell you what we have been doing at Shifa. So we have probably operated upon almost 60 or 70 patients with pancreatic cancer. And I'm going to stick to pancreatic cancer because this trial is about pancreatic cancer. So we're obviously not talking about other periampullary tumors at all. Out of those 60 patients, there is only one patient who survived for 5 years. And that one patient had a 1.5 centimeter pancreatic head tumor in the background of IPM and IS. Other than that, we have had maybe 4 or 5 patients who survived for 2, 3, or 4 years. All of them were dead within 2 years otherwise. So my point is, what benefit are we giving these patients? Again, strictly talking about pancreatic cancer, by doing surgery and maybe giving them adjuvant chemotherapy that we know not more than 50% patients can actually complete adjuvant chemotherapy. So definitely when we're talking about pancreatic cancer, we need to change our approach. There is no question about that. I agree that at present, the chemotherapy that we're using is not so effective as it is in some of the other cancers like rectal cancer and breast cancer. I also agree that, you know, if you go down the neoadjuvant route, it's very difficult because you have to get a biopsy. Sometimes the biopsy is negative, so you have to wait, get another biopsy. You have to get these patients stented, you know, then the stents have their own complications. You need to do a staging laparoscopy. Where are you going to do that? So, I mean, these are all problems and we need to have realistic guidelines. I totally agree. But I think we should not sit comfortable thinking that, you know, pancreatic cancer is going to, you know, do really well with surgery and adjuvant chemotherapy. It has been proven worldwide that pancreatic cancer is a bad disease and we need some sort of maybe chemotherapy, immunotherapy, maybe some sort of genetic mutation analysis to select patients and then operate upon them, because it is associated with significant morbidity and mortality if you go for operation.
Thank you very much, sir. And these are all very important comments. Another comment within our chat by Dr. Mohammed Zaib is echoing the same issues that we need to have local data, and based on that data, we need to come up with local solutions. And I think it's very important. If any of the audience has any questions or comments, please post them in the chat. We will look at them and ask our faculty to address them. Speaking of local groups, I do recall about 4 or 5 years ago, we formed a local group within Karachi for borderline resectable pancreatic cancer, and actually came up with a strategy of using modified FOLFIRINOX regime for these patients, which was that we would select these patients, discuss them in our tumor board, which is a citywide tumor board, and then take these on for the modified FOLFIRINOX regime. At the end of 3 or 4 cycles, we would reassess them, and if they have not progressed, then further move to radiation therapy and then surgery. Although when we started, and this session actually started from our SOS-PK WhatsApp group, but majority of the people included in this were from Karachi. There was only one patient that came forward, and I particularly recall that patient because I put that patient in the group, who eventually progressed after 3 cycles of FOLFIRINOX. And because there were nobody contributing to the group, it just kind of died off. So yes, there are initiatives, but eventually all of us need to kind of contribute to such initiatives. And I think we are very lucky that we have high volume centers like Shaukat Khanam, like the transplant unit at Shifa, that actually produce, and I can say that about Sheikh Zayed at Lahore and Pikli, as Professor Harun Javed has mentioned. There are these centers. That Dr. Taki is here from Dow University of Health Sciences, who have also got a transplant unit and are actually high volume hepatopancreatic biliary surgeons. These units need to come together, and I think if I'm allowed to say, Professor Harun, I think society needs to take this lead on and probably create focus working groups for each of these diseases.
Thank you, Raza. I think that should be considered as a first step, getting a group together and start talking about it on one platform.
Where is he?
I think if in the interest of our audience who are either trainees or young surgeons, maybe we should ask the question while we have such a stellar faculty, which of these, which patients who present with obstructive jaundice and are found to have periampullary or hepatopancreas tumor, which of these would you go for a pre-operative biliary stenting? I know this is a age-old debate which has probably been answered by evidence, but it's important to answer this question as so many of our trainees are around.
I can very quickly say, if I had a choice, nobody should get stented.
Professor Harun, Dr. Abu Bakr, Professor Durrani, what would be your practice?
Generally, what our practice at Zayed has been that we offer stents to those patients. I mean, we would want to avoid the stent, obviously, for the personal reason, but I personally feel that stent makes surgery slightly more difficult. However, we offer stents to those patients who are physically very frail, who need nutritional rehabilitation, and who have very, very deep obstructive jaundice. Generally, bilirubin level of 15 or more, we tend to get them stented. But somebody with bilirubin of 15 and in very good physiological condition, and a younger patient and not nutritionally depleted, we would still go ahead and operate without a stent. So, there's not a definite criteria with us for getting them stented.
Yes, I also agree with Dr. Majid. I mean, generally, I would their bilirubin is below 15 milligrams per deciliter, but it's not in my hands really, because most of the times when I get patients, they're stented, biopsied, and then they're. But yes, I mean, if you don't have stents, I think complications. There's no doubt about it.
Professor Durrani?
Yes. On a lighter note, I may be allowed to say that this is called a barber's phenomena, which means that anybody who sits on a barber's chair gets a haircut. So since we had at Sheikh Zayed during my time, we had the most well-equipped and skilled gastroenterology unit. So any patient with obstructive jaundice and a suspicion of pancreatic cancer was referred, he used to get a stent. And we certainly, I can say to you that the surgery becomes far more difficult in the presence of stent with edema and increased vascularity. The whole dissection becomes very difficult. So I think if the bilirubin is within 20 milligram and the patient's renal profile is okay, then I in a resectable patient who is anatomically and biologically and physiologically fit for resection, we should go for upfront surgery. Yet another point, I think our colleague from Shaukat Khanam, Peshawar, has seen probably far more periampullary tumors. In my days now, for the last 3 years, I am away from my patient, but during my time when we had a lot of interest in pancreatic surgery, I think we used to get 50% of our patients were periampullary tumor and 50% of our patients were pancreatic head tumors. So probably it is, maybe there is distribution is like that. So I just want to convey that pancreatic head tumors are not rare in this part of the world. We do see it. And now Dr. Harun is at the helm of affairs. He would say He must be able
Professor
to
Rani,
comment.
just a short comment on this? That if you look at Shaukat Khanum data, yes, maybe you get many more peri-ampullaries. But the Shehzad data with the 2 units of general surgery and surgical oncology, I don't know about the HPV units. We get possibly about 50% pancreatic cancer, and the vast majority are beyond surgical help. So basically, the patients at Sheikh Zayed who are coming to the operating table are smaller tumors and in the periampullary region. But the vast majority of the pancreatic tumors that we see are only for palliation, and they're stashed. They get permanent stents and taken care of that way. So I think it has to do with the different hospitals as well and the selection criteria.
We also have to look at how patients actually go on to Shaukat Khanum Hospital. They pass through a center which more or less screens out advanced cancers. And even though the population incidence of these cancers may be equal, just because the pancreatic cancers are much more advanced, a lot of vast majority of them are screened out by the center acceptance criteria. Would you agree, Dr. Irfan, this understanding of why so many periampullaries, ampullary carcinomas are seen?
Well, I think that's the answer is fairly obvious. I think there's a big screening process, and like all my colleagues, distinguished colleagues have said, majority of the pancreatic cancers that we do get are beyond the certain stage where you can offer surgery, at least in any reasonable manner. And I think with our criteria, you're more likely to get operable periampullary tumors rather than pancreatic tumors. And I think that's why we get more periampullary than pancreatic. And I think this is a fairly obvious answer to that question.
Yes, and Dr. Muzna has also possibly pointed out that ampullary and periampullary perhaps present earlier compared to pancreatic cancer because of their
exactly. They get jaundice earlier. You get them you catch them at a much early stage. Where with the pancreatic, generally speaking, they start getting either diabetes a year before they get diagnosed, either they start getting malabsorption a year before, but in the community they don't get picked up that quickly, and that's why they're known as the silent killers. And by the time somebody decides to do a CT scan or something, it's usually too late. I mean, that's what my experience has been in England as well as over here. Interestingly, with the periampullary, what I found is we've done some very big tumors, like 5 centimeters, 6 centimeters, and sometimes even bigger than that, and they've done okay comparatively. So I think periampullary is not I won't say it's not a bad disease, probably it is a bad disease, but not as bad as pancreatic cancer.
Yes, I would also agree with that. And I mean, definitely, and it has been proven in other studies as well. And I mean, I was looking at our data as well. So the 5-year survival for non-pancreatic periampullary tumors at our center is probably close to 50%. And the 5-year survival for pancreatic cancer is probably, I think, 7 or 8%. So there's a huge difference. There's no doubt about that.
Thank you. Maybe we'll entertain a few more questions just because we have such a stellar faculty around, especially directed to Dr. Fariha. So if a patient who we feel has got borderline resectable pancreatic cancer with involvement of the portal vein or superior mesenteric vein and portal vein junction, along with a small area of contact with SMA. And in the tumor board, we do identify these patients that perhaps it will be more appropriate if they receive neoadjuvant therapy. What would be your neoadjuvant therapy of choice in a patient with borderline resectable pancreatic cancer in our population who has got a reasonable functional status?
If a patient is young and has got a reasonable performance status with no co-mobs, only then we choose FOLFIRINOX. Otherwise, capox, or if a patient is not having that good performance status, then we go for JAM, NAP, paclitaxel. Depending upon the performance status of the patient, we choose the regimen. We choose FOLFIRINOX only for those patients who are young with no comobs and they are very robust to tolerate that triple agent chemotherapy regimen.
On that note, can I just add one experience? I think I've been in Pakistan for about coming up to 3 years now. And I think in these 3 years, I've seen 5 patients who've had a neoadjuvant approach for a borderline resectable pancreatic tumor with vein involvement in the preoperative staging system. And I think 3 of them had surgery, and R0 margin was there and they did well. And one patient recently in Peshawar actually had complete pathological response. That was on histology. Afterwards, we couldn't find the tumor. Now, you could argue whether the diagnosis was correct in the beginning or not, so I don't know about that. But we've had one patient on FOLFIRINOX with complete pathological response, so lucky patient.
I would like to make a comment. When I was in Shaukat Khanam, I have seen a patient which was unresectable at the beginning, and we started him on palliative chemotherapy. And after 5 or 6 cycles of chemotherapy, there was complete response, and we could not identify tumor on imaging. So he was on follow-up, and so far I remember after 2.5 years, he was still alive, and there was no disease relapse. So there are few patients who respond very well to chemotherapy, but again, that depends upon the tumor biology. Which patient will respond?
I've seen one similar patient about 5 years back. Also, the patient had been treated in referred by Mayo Hospital to ourselves as with vein involvement, and he'd been referred for a stent. And the ERCP people could not get a stent in. It was the tumor was in the head region, and there was no previous histopathology, but it was labeled as a pancreatic head tumor. And so our IR people took him on, and they did a PTBD stent. The stent somehow misfired, and the patient had biliary peritonitis. And when we explored him, the stent was sticking out of the left cardiac duct and pancreatitis. So I just did a cholecystectomy and enterobiliary bypass using a rule loop, and the patient survived that. And after that, he was desperate for a definitive surgery. So he had already been labeled as irresectable, inoperable, beyond help. So we let him go to adjuvant chemotherapy, etc. He went overseas to Singapore also, and he kept on following up for about a year or more, and then he disappeared. I thought that was bad news. The gentleman turns up 3.5 years later with a CT scan from Singapore that they could not find a tumor there now. So what had been dealing with possibly chronic, some form of pancreatitis maybe, and this chap received full chemotherapy and everything. So cases happen, but I'm yet to see a biopsy proven pancreatic cancer resolved completely on chemotherapy.
I think we're too far to say that eventually we will have patients who will be completely cured by chemotherapy and will not require any. Still, we will have to say that there are a few patients who have better response than others, but we cannot identify these patients just on the basis of histopathology or CT scan alone. Professor Khalid, your comments, sir?
As Dr. Haroon was saying, I also I can recall that we also experienced a patient in which we had done pancreaticoduodenectomy, and the histologist was confused. She would say, sometimes she would say it looks like a pre-malignant condition, and at other times she would say, though, no, it is more like an inflammatory condition. And finally, she resorted to the diagnosis of autoimmune pancreatitis when we had done the blood levels. So an interesting point to note that sometimes these autoimmune pancreatitis in the region of the head will mimic pancreatic cancer. And the only way to confirm is the IgG level at a 2 to 3 weeks course of steroids. It will completely disappear. So maybe the patient who went to Singapore was suffering from some of these conditions. Otherwise, if you look at the literature, the pathological response in pancreatic cancer is less than 4 to 5%. It is not as good as you see in rectal cancer or, for that matter, in esophageal cancer. So these patients are highly lucky if they get complete pathological response. Thank you.
Thank you very much. Maybe one last question for the benefit of the audience. What is the extent of lymph resection that you would perform with a standard pancreatectomy for either pancreatic or periampullary? Is it different in different biologies?
May I? Hello?
Sure, sir. Please, sir.
Yes, sir.
In periampullary tumor, I think the pylorus preserving pancreatic otorhinectomy is a reasonable option. But in pancreatic head cancer, which is close to the pylorus, probably the standard Whipple operation would be justified. The other point I would like to say is that the current concept of artery first approach has become very popular, and several studies have shown that this is more likely to achieve an R0 resection, and also the lymph node yield is also better. And if you look at the data from the ASPECT trials, or for that matter, the Center for ASPECT trial is, I'm sure you people would be knowing, is University of Heidelberg. Their own data, from their own data, you would see that the total number of lymph node yield is somewhere between 20 to 30. This is something which is amazing. I don't recall any of our patients that we resected at Sheikh Zayed. We could get more than 10 lymph nodes by performing either a standard Whipple operation, including entrectomy, or a pylorus preserving pancreatic otorhinectomy. But now they are promoting this concept of the artery first approach, and there are several studies on artery first approach in which the yield is much better and the clearance, because if you recall, the older data would show a very high number of R1 resections. Now with this artery first approach and clearing the space between the portal vein and the superior mesenteric artery, and divestment of the superior mesenteric artery in those cases in which the tumor is very close to or is abetting the artery, the lymphatic lymph node yield is always much better, and these patients certainly will have a better outcome. Thank you.
Dr. Raza, please allow me to comment. Please allow me to comment on this one regarding the lymph node yield.
Yes, sir.
Looking at lymph node yields, we're also at the mercy of the histopathologist. So it depends on how they're dealing with the specimen, how they understand the specimen, and you see whether there's, our previous series, the yields of 10 or lymph nodes or less, because the histopathologists were not guided by the surgery people or the surgery residents. I think less serious dissections of the specimen were made, and only big lymph nodes which were clearly visible were taken out to quickly get over the workload and just give you a few lymph nodes. But if now what our residents are doing, they are going down with all other cancer specimens also, showing the histopathologist what is what and then where to look. And we repeatedly, if we get a low lymph node yield, we go and ask them again, and they look at it again, and then they give us a couple of more lymph nodes on it. So that means those lymph nodes are there. So, and the other method, whether the dissection method or you send the same specimen to say the Shaukat Khanum lab, you get double the number of lymph node yield. Then the technique, whether dissection method is being used or they're putting it in finally in a fat solvent, and looking at all the angur ka gucha and the lymphatics that turn out, that gives you a higher lymph node yield. So, Professor Durrani, in the last 2 years, since we organized the services over here, we are continuously in touch with pathology, and I think we are going down practically for every specimen now. So, that's how things go.
So, carrying on from my distinguished colleagues there, I think our approach is the same. If it's uncinate process tumor, we go for artery first approach, and if it's periampullary, we go for a standard lymphadenectomy approach. I think, just to make a comment, Heidelberg has got really great data, but I don't think any other center has ever been able to replicate their results anywhere in the world, whether it's Japan, whether it's Europe, whether it's America, whether it's England. I don't think anybody's been able to replicate Heidelberg, so I'm not quite sure what they do there, which other centers are not doing. But apart from Heidelberg, no other center has shown an overall survival advantage to an increased lymph node dissection. What it has done is increase the staging process in a
I think the audio got disrupted in between, Dr. Irfan.
So yeah, I was just kind of saying that I'm not quite sure where I got cut off, but I think lymph node yield is important, and I think we should aim for at least a minimum of 15, but I don't think it adds to the overall survival. That's my thoughts.
Okay, I think we're reaching more than 90 minutes of discussion, and I think we should call it a day, unless any of the faculty members have any more comments.
Yes, Dr. Raza, I actually, I'm going to take the benefit of this, faculty, and I would like to ask a question. So what, regions of lymph nodes in terms of the extent of lymphadenectomy are, individual surgeons practicing, like, for example, the common hepatic artery lymph nodes, the para-aortic lymph nodes, the jejunal mesentery lymph nodes. So I would just want to know, how far do we go when we're doing a pancreatic duodenectomy?
Dr. Patti, our practice is we don't do extended lymphadenectomy. At least I don't. Some of my colleagues might. So we do the common hepatic, we do the periportal region, anterior, posterior. We do para-aortic lymph node sampling. I don't do clearance of the para-aortic area. I just do sampling. We send it off, and it's more for the staging rather than thinking that it's going to stop me from operating. And we do the peripancreatic tissue, so the mesopancreatic tissue. That's the area which we take out. So we try and take out the whole uncinate, and we try and go beyond, at least on the left side of the artery is where we tend to kind of come up to, if we can. But I tend not to do circumferential dissection of the artery, because I think it leads to more morbidity, and I don't think it adds to any advantage in the lifestyle.
Agreed.
Okay, I think I will thank everyone. First of all, Dr. Muzna, who gave an excellent presentation and overview of the article, our distinguished faculty, and all the participants. Thank you very much for your attendance. We will have the next session on the 2nd of July, and we will communicate the details of the article in the faculty in the coming week or so. Thank you everyone for attending. I would request Professor Haroon to kindly conclude this session with his remarks.
Thank you, Raza. And I think this idea of the journal club on a regular basis, which originated from yourself, has been wonderful. And it has been most popular among the trainees and residents especially. I would like to thank on behalf of the Surgical Oncology Society of Pakistan and my own department at Sheikh Zayed Hospital, because Dr. Mosna, who did a beautiful presentation, is one of my own residents. So, and I would like to thank Dr. Faria, Dr. Abu Bakr, and Dr. Irfan. And Dr. Irfan, we hear a lot about you from our former residents who now work for you or have been working for you. And I would like to thank Professor Khalid Durrani and all the other people who joined us today. Thank you very much. And I would strongly like all of you to consider the idea of a pancreatic think tank or a pancreatic group on a national level, so we can start talking about these things. So with that, I would like to thank you all again and goodbye. Allah Hafiz.